Thank you for joining the National Headache Foundation's Allergy and Migraine webinar. Today we have joined with us Dr. Wade Cooper of the University of Michigan. Dr. Cooper has served as a medical reviewer for several pain journals and has published multiple articles focusing on diagnosis and treatment of headache and pain syndromes. Dr. Cooper, thank you for joining us.
My pleasure. Hello to everyone listening in on this webinar. And I'm delighted that you took time out of your day to hear about migraine, about headache, and the relationship between allergy, both systemic as well as local allergy issues. My understanding is that there'll be opportunities to ask questions in the chat box, and we'll be addressing those questions after discussing the main topics in front of us. So you can follow along with the slides right in front of you. And I'm going to go to the first place to start is really what is migraine. And I'm certain for those listening in, some of you may actually have migraine and being treated for migraine, but it's really important to kind of start there, and we can build on the concept of allergy as it relates to migraine. Migraine is a chronic disorder and has episodes of attacks, and it's integrated to most other nervous system functions in the rest of the body. And it's important to pause there and realize almost everyone in the world can have migraine. We all have the same nerve bundles for this, and some people initiate the reflex deep in the brainstem that we call migraine far easier than others do. And what I mean by this is if there's enough energy that builds up and stimulates the area of the brain that controls migraine, then you get an active experience that causes the rest of the cascade to occur. What that really means is if someone goes into a migraine episode, once that's started, lots of important things happen in the body and around the brain as part of that migraine experience. We know that during an attack, people have headache, which is what most people find most troublesome about migraine, but there's also a bunch of associated symptoms. This includes light and sound sensitivity, this can include nausea, and this can include other areas of nervous system hypersensitivity. And a lot of this results in functional disability, meaning that people can't do what's important to them during an episode of migraine. That might be work, that might be caring for their family members. Some people are just flat out incapacitated during a migraine attack. We know that in between attacks, people can have sensitivity above the baseline for most other people, meaning that even in between attacks, people's nervous systems are more sensitive. And we know this if you study how people respond to light and sound stimulus when they're prone to have migraines, even when they're feeling well, people will describe more sensitivity to the light or more sensitivity to the sound stimulus than those who don't experience episodes of migraine. We know that people can be concerned about the next experience of migraine, and we also know that this can predispose them or make them more likely to have more migraine, so that the more often the body experiences migraine, the less it takes to initiate that experience the next time around. So the next thing I've done is I've included the criteria to diagnose someone with migraine headache. So if someone has migraine, their headaches typically last between 4 and 72 hours. They typically have moderate to severe intensity of headache, and it's aggravated by physical activity. Those are the most common descriptors that people fit into. And then during the headache, they have to have at least one of the following, either nausea or light and sound sensitivity. And again, all of this represents the hypersensitivity of the brain, meaning that the brain is operating at a normal level, but then it can go into these episodes where the sensory input from light or sound, or for some people smell, for some people position sense, for some people the rest of their body sensation, like feeling hot and cold, is just overly charged up and overly sensitive, and it's almost like they have an enhanced or supercharged nervous system. There's even been that statement that those people who are prone to have migraine, it's almost as if their nervous system is like a Ferrari or a sports car, where it's high performance and it's an enhanced nervous system, but unfortunately it's also high maintenance. And therefore skipping meals, having a mess up in the sleep schedule, or those types of concerns are more impactful if your body's prone to have migraine than for those people who aren't prone to have migraine. So if you were to ask how many people actually qualify for a diagnosis of migraine, the most common number reported out there is about 28 million migraineurs. We know that number is not actually correct. It's actually much higher than that, because the study that everyone talks about didn't include adolescents, and it didn't include people who had only moderate intensity headache. So we really think there's actually more than 35 million migraineurs in the United States, and this information is about 10 years old. What's kind of crazy about this study is that even though there's more than 35 million United States people and residents of the United States who have migraine, only about half of them have the right diagnosis. The rest of those who have symptoms that fulfill criteria for migraine are thought to have other headache syndromes that have been misdiagnosed. Things such as tension headache, things such as stress headache or sick headache, or even sinus headache or allergy-related headache, which kind of leads us into a discussion for today's topic. So this is kind of cool. When someone shows up at a primary care physician's office and they're being seen for a headache, the primary care physician will do a detailed examination and come up with the diagnosis based on someone's symptoms. It's been found that if someone shows up at a primary care doctor's clinic and says, I think I've got migraine, they're right 99% of the time. We also know that if someone shows up at a primary care physician's office and the primary care physician does their due diligence, does a detailed examination, and does a careful review of history and makes a diagnosis of migraine. And when that diagnosis is made as migraine, when someone shows up with a recurrent headache episode to the primary care physician's office, the physician is actually correct 94% of the time. It turns out, though, that if the physician who hears the story and hears the symptoms says it's migraine, when it's really not, that is very rare. That only occurs 6% of the time. So if a patient thinks it's migraine, it's migraine. If a physician thinks it's migraine, it's almost always going to be migraine. Here's where things get a bit complicated. If someone shows up at a primary care physician's office and says, I don't think I have migraine, even though I've got recurrent episodes of headache, when they show up in the physician's office, when they say I've got something else besides migraine, like sinus headache or like headache related to my allergies, it turns out they're wrong. 86% of the time when the patient says I don't have migraine, I've got something else, they actually do have migraine. And that's based on taking a 3-month historical database, looking at their symptoms, and then applying the criteria for diagnosing migraine. And here's the clincher. When the clinician themselves hears the story and does their detailed examination and thinks as hard as they can about what possibly could be going on and says, you know what, I don't think you have migraine, they're wrong also. More than 80% of the time, when a physician says you don't have migraine, you've got some other headache syndrome in the primary care setting, they're wrong. They're wrong about 80% of the time. So how do you differentiate between sinus headache and migraine? And if we look at the ENT data, that's ear, nose, and throat physicians, people who specialize in the nose, specialize in the throat, specialize in the sinuses, it turns out based on their criteria, headache from sinus disease is rarely disabling. Meaning if someone says I've got a bad sinus infection and I've got to stay home from work or I can't take care of my family because of it, that is almost never because of a sinus headache. It's usually because of migraine. Also, a sinus headache is rarely associated with nausea, and it's rarely associated with lighter sound sensitivity. So if someone says I've got a really bad sinus infection or I've got allergies affecting my sinuses, but they have lighter sound sensitivity or they've got nausea, it's almost never because of sinus disease. And it's almost always because of migraine. There are some key exceptions to this. There's something in the back of the sinus cavity called the sphenoid sinus. And if the sphenoid sinus is infected or inflamed, that can generate persistent migraine for people. And chronic sinusitis, meaning recurrent inflammation of the sinus cavities that comes and goes but is there to some degree all the time, that can also generate a persistent amount of pain. So why the heck do people keep confusing sinus symptoms for migraine? And there's a couple reasons for this. This slide is somewhat detailed, but it's supposed to show the pain nerves of the face, which are also the nerves that supply pain to the lining of the brain all the way to the top of the head and supply pain all the way of the lining of the brain into the back behind the ears. When those nerves are irritated, you can actually turn on certain pieces of those nerves that make people have a runny nose. So in plain migraine, about 1 in 3 people can actually get stuffiness of their nose or a fullness of their nasal passages, feeling as if they got inflammation in their nose. We also know that part of migraine can cause people to have watery eyes. And that same nerve bundle that controls pain to the lining of the brain is directly tied into a nerve bundle that controls watering of the eyes. So if you stimulate one pathway, one nerve branch, you can actually get watering of the eyes even though it's purely from migraine. And the next confusing piece is that many people who have migraine will use an over-the-counter medicine such as a sinus treatment like Excedrin sinus, or they'll use Benadryl and feel better. And we know that those medications actually can be very effective for those people who have sinus disease. But they also can be very effective for people who have plain migraine. So if the bottle says Excedrin sinus and their pain gets better, people feel like they actually have a sinus problem, when really it could very well be just plain migraine generating those symptoms. So there's one specific nerve bundle I really want to talk about because it kind of links all this together. It's got a really weird name. It's called the Sphenopalatine Ganglia. And this is actually a bundle of nerves deep in the cheek. And actually, if you were to take a very long Q-tip and stick it right in your nostril and press it directly back to the most back portion of the skull, you may actually come close to touching this nerve bundle called the Sphenopalatine Ganglia. The Sphenopalatine Ganglia regulates not only pain to the face and to some degree pain to the lining of the brain where migraine is felt, but it also regulates eye watering, regulates the nasal stuffiness, and even regulates facial swelling for some people. So if as part of migraine this nerve bundle gets activated, you can see they could develop eye watering or nasal stuffiness or facial swelling because of that. The Sphenopalatine Ganglia has recently been studied as a kind of a key control center for migraine. And there's even some new therapies, including some stimulators that surgeons implant in very severe cases, even up to some devices which actually drip numbing medicine through the nose that your physician can do that can numb this bundle. And although there's not much research yet associated with that, the results that I've heard about and seen have been absolutely fantastic for plain migraine and for facial pain. So the next thing is I want to show you this picture. This is actually a picture of someone's nose during what they thought was an allergy attack affecting their nose. And indeed, I know it's kind of hard to visualize what the heck this is. This is where an ear, nose, and throat doctor takes a picture right up the nostril. And what I'm trying to show in that picture is that it's pink and it's boggy and it's kind of thick and slimy, just like you'd expect an inflamed nose to look like. The next picture I want to show you is that same person's nose, but this is 1 hour later after their doctor treated the source of their swelling and inflamed nose. And what's so cool about this picture is they did not spray anything up the nose to make the nose feel better, and they did not treat them with any specific allergy medicine to make the nose become less inflamed, as the picture looks like on the right side. And you can see in that picture where the center portion of the nose called the turbinate is less puffy and less inflamed. What they did is they gave this person a medication called Imitrex. And Imitrex is a medicine that stops migraine. So by shutting off migraine, this person's nose in 1 hour actually went from an inflamed, boogery mess into being a little bit more normal appearing nose without all the inflammation around it. And that shows that nasal stuffiness was actually being controlled by migraine and not being controlled by an allergy response or those types of things. So what about allergy and migraine? This is really kind of cool. Some people have talked about migraine as being brain hives, almost as if the lining of the brain becomes so irritated it starts irritating itself. And indeed, the lining of the brain is controlled by some degree by the nerves of pain, these nerves called the trigeminal nerves, and those surround the lining of the brain. And when those irritate or when those turn on migraine, they secrete an inflammation cascade over the surface of the brain. And some people even call it brain hives. It's like the brain itself has an allergy response, so it becomes too inflamed for a period of time. And what's cool about this, and I wanted to make sure we talked a bit about this, is that when rats were given an allergy-generating injection, the lining of the rat's brain became inflamed. So they actually injected the animal in the leg, and because of the body's inflammation, it also caused inflammation of the lining of the brain. And when they gave that same lab animal Benadryl, the inflammation of the lining of the brain got better. So we know that if you cause an allergy response in an animal's body, you can see that turn on inflammation of the lining of the brain. And in theory, that can be just like a migraine episode. Now, just below that statement is the second statement. People with migraine have higher blood levels of histamine. Histamine is actually a marker of inflammation and commonly seen in allergy response. You may be familiar with antihistamine therapies. Those are medicines that calm down histamines, meaning they make people feel less itchy and have less stuffiness of their nose and have a less inflamed feeling of their body. And we know that people who are prone to have migraine, they sometimes have a higher blood level of these histamines, both during a migraine attack, where those levels go quite high, and even in between migraine attacks. When they're not feeling any migraine symptoms at all, they can still have a higher level of histamine compared to people who are not prone to get migraine. This is really kind of cool too. If you look at people who have a diagnosis of sinus headache, they actually fulfill criteria for migraine in more than almost 3,000 patients. Very few of them had tension headache, very few of them had other things, but almost all of them, about 80% of the people seen in the doctor's office for sinus headache, actually had migraine or probable migraine. Again, here's some allergy symptoms in migraine patients. So people who've got plain migraine and no active allergy, they can develop red eyes. They can develop tearing of their eyes. They can get nasal congestion. They can get swelling of their eyelids. And they can also get drooping of their eyelids and pupil changes. These are commonly seen in plain migraine, but if you didn't know that and you looked in someone's face and they saw red tearing eyes and nasal stuffiness and swelling around the eyes, you'd say, boy, it looks like they're having an allergy response. So that's pretty much showing that people who are prone to have migraine are prone to show features of allergy inflammation. But the other way, but looking at this from the other direction is very true too. So if someone's prone to have allergic rhinitis, and that's where people have environmental sensitivities to make their nose run or nose feel stuffy, they're far more likely to have migraine than people who don't have allergic rhinitis. The theory here is that if someone has enough inflammation of the nose, it can go the other direction. It can actually turn on or irritate the lining of the brain, or it can turn on and irritate the migraine system. So allergic rhinitis can be triggering or can bring out migraine in people. And there's a few more studies. These are actually stolen from Dr. Vincent Martin, and I want to share this information Dr. Martin has generated. We know that if you look at people who live in an HMO or who are participants of an HMO who live within 15 miles of an allergy counting station, that when there's high allergy counts, the expenses for their health care, including ER utilization, as well as including migraine medications, goes up. And in times when the allergy flares are less in the environment, the cost for treating migraine, the cost for treating ER visits for migraine goes down, meaning there's a direct relationship to how allergy-focused the environment is and how likely people have needs for services for migraine flares. Essentially what that means is during allergy season, people are more prone to have migraine, and that's a large population study that was done to show that. So I want to show this clip here.
Well, how much are they asking?
Well, that's a lot of money for a deck.
Well, I hate to tell you this, but you're getting robbed. Did you hear me? You're getting robbed. Ow! Stop!
And the whole point to show this clip is that we know that people who show up at their physician's office and say I'm having migraine, sometimes are going to have allergies as a source of this. And many times it's going to be misinterpreted. So the clinician hears this description and says you're probably having migraine, when indeed you might be having an allergy issue generating migraine. And there's a tight association between those two. Part of that association is from a very important regulator of allergy in the body. These are things called mast cells. And mast cells are allergy-related cells in the body. They live in not only the breathing and lung tracts in the body, but they also are found throughout the skin in the body. They're found through the joints of the body. They're found in the tissue that combines muscles to the joints of the body. And pretty much everything, every tissue in the body, every portion of meat and every organ system has mast cells that are regulating inflammation response. Now mast cells, if you talk to allergists, are very important for releasing something called IgE. And IgE is an inflammation marker, a marker of inflammation, but it's quite specific. When people have an issue with IgE, you usually hear about it from things like food allergies. So if someone ate an egg or a peanut that they're allergic to, then the body releases this IgE inflammation marker from mast cells, and that causes histamine to be released and irritate the body, and it causes all the things that we think of when we think of an allergy response. So when you see people who've got pain syndromes like arthritis, or pain syndromes like fibromyalgia, or pain syndromes like painful bladder syndrome, these folks are actually prone to have problems with mast cells, and they're prone to have inflamed markers elevated more so than people who don't have those pain syndromes. Meaning if you have arthritis, or if you have fibromyalgia or painful bladder syndrome, you're more likely to have active mast cells than people who don't have those pain syndromes. Essentially, if you have those things, you're more prone to be sensitive to allergies. So if we take a step back and look at the big picture, and look at the world in front of us, we'll find that the world of migraine is not just related to the nervous system and the brain and the spinal cord, but the world of migraine is actually related to the entire body, and that things that happen in the rest of the body can affect the brain and spinal cord and can trigger migraine, just like migraine can cause effects in the rest of the body. So we know this from that animal study I mentioned. If you cause the animal to be exposed to an allergen by giving it an IV of allergy in its body, it causes the brain to become inflamed with that rat. And if you treat that rat with Benadryl, it causes the brain to become less inflamed. And it's important that clinicians and doctors know this, but also patients know this too. So if they're being exposed to an allergen, say in their diet, or exposed to an allergen in their environment, that could irritate or bring out persistent migraine. Let me tell you what I'm talking about. So with these mast cells in migraine, those cells that regulate inflammation of the body, we know that they live in the lining of the brain. We know that those mast cells are very close to important blood vessels that control blood flow, like throbbing blood flow, that control blood flow that can regulate the inflammation of the brain, and that if you irritate the mast cells and the lining of the brain, they release the same inflammation markers that they would elsewhere in the body. We also know if you use histamine injection, that can trigger a migraine episode. We know that these mast cells, the ones that control allergy response in the body or help regulate allergy response in the body, can become more likely to cause trouble around times of stress and are more likely to become active and release inflammation markers when there's estrogen fluctuation, such as around the time of a woman's period. We also know certain foods can irritate these mast cells and make them release inflammation markers, and alcohol can bring out this inflammation too. So that some people who have these linings, their brain is lined with these mast cells, if they're around stress, if they're around foods the body doesn't like, if they're around alcohol, can make the lining of the brain become inflamed just because of that, and that gives them the activation of migraine. You can essentially trigger migraine from being around some of these triggers. So what does this really look like? And this is kind of a complicated slide, but it shows the key players in the nervous system. The nociceptor, that blue looking squiggle thing on the top left, is actually a pain fiber. We know that the green thing on the right is the cell that controls inflammation. And then the orange thing is actually how the body senses inflammation, and it's part of the nervous system. So when you have an activation of the pain fiber, we know that that causes release of markers to irritate that green mast cell. That green mast cell then releases things that inflame the nervous system, like histamine and things like growth factor and things called tumor necrosis factor alpha, which then cause more irritation to that pain nerve and also irritate surrounding structures like blood vessels and the lining of the brain itself. And voila, you've got this perfect stew of building inflammation, building sensory trouble for the lining of the brain, which causes migraine symptoms to occur. So here's activated mast cells, and if you look at the screen, you'll find that those mast cells in the bottom, that's what they look like under a high-powered microscope. When they release their substances, you see these little squiggles that start showing up. That's actually histamine pockets, and those get secreted to around where the mast cells are. And not only do these mast cells release histamine, but they also release things like serotonin. They release inflammation markers called leukotrienes. They release prostaglandins, which is what things like ibuprofen and naproxen work on. And they actually release more than 60 different things. Some of these control blood pressure. Some of these control the swelling of the nose. Some of these control how your blood sticks together. Some of these control how much serotonin or norepinephrine flows in the body and regulates how much is squirted out. So you can see if these cells become too irritable and squirt out medicine or squirt out these markers more than they're supposed to, that can cause all kinds of trouble to the body. Not just classic migraine, but it can make people feel lightheaded, make people feel nausea, make people feel clumsy or confused, make people have abdominal pain, like diarrhea during a migraine episode. Things that aren't classic for migraine, but when we hear those, we think someone might have an allergy response generating migraine symptoms. And this other slide also says that people who have flexible bodies, also known as connective tissue disorders, but people who are really flexible. And this is people who when they were in high school, they could do flexible things with their thumb, or they've got a kneecap that always seems to pull off to one side, or they've got joints that dislocate on their own. We know that those people with flexible bodies have more of these mast cells in their bodies than people who don't have flexibility, as well as those mast cells are more active than people who don't have hyperflexible bodies. So the bottom line is, if your body's more flexible, more stretchy, for lack of better words, you're more prone to have mast cell inflammation in general. Clearly, that doesn't mean if you're flexible you have a problem with inflammation, but it makes you more likely just based on how your body's put together. Essentially, more flexible body, the more likely you have extra mast cells, and the more likely they are to become inflamed or irritated with minor irritants. Here's what I mean by hypermobility. So that top right picture actually shows the movements we test for to see if someone has a musculoskeletal system that's more flexible than it's supposed to. For people who are over age 18, they should only be able to do 1 or 2 of those pictures. If you can do more than 2 of those pictures, you're more likely to have a hypermobility syndrome, and that would put you at a higher risk to have not only an allergy issue, but also at higher risk to have other pain syndromes, like fibromyalgia, like chronic daily headache, like pelvic pain syndromes, like spine pain issues at young ages. And this is that whole concept that the more hypermobile you are, the more your body has a problem regulating inflammation and therefore regulating some of the pain markers out there. To make this example even more clear, there's actually a patient of mine who has given me permission to use her pictures. And so she comes to see us for a headache that began one day out of the blue, and it's been present on a daily basis ever since. And you can see from these pictures that not only does her thumb touch her wrist very easily with just pulling on it, but her fingers stretch beyond 90 degrees when you pull them back. Her neck rotates both side to side, as well as she's able to bend the side of her ear down to her shoulder very easily. All of those are features of people who have hypermobility or more flexible bodies. The theory behind this is that she's more prone to go into chronic daily headache from a minimal stimulus. This is a patient of ours who came to see us with not only really intense chronic migraine, but also persistent abdominal pain, episodes of diarrhea. And although you can't hear the sound clip, she describes at times feeling itchy for no reason, or having near fainting episodes or fast heartbeats for no reason. It turns out that her symptoms fit better with someone who has a problem with an allergy response in the body, something called mast cell activation syndrome. And about 5 years ago, this mast cell activation syndrome wasn't even a well-known entity, and it's only just recently that pain doctors, headache doctors, and other doctors from other areas of specialty have started to really understand and appreciate what happens when people have mast cells that are too active in their body. So people who have mast cell activation syndrome actually can get episodes of flushing. And we think that's because the mast cells, when they become too active, release markers that cause swelling or inflammation of the cheeks and the rest of the chest wall. So they can get red or flush out of the blue. They can get abdominal pain and have episodes of diarrhea. So when we hear patients who've got migraine features, but then get episodes of near fainting or flushing, or get episodes of diarrhea with their migraine episode, we start thinking, could they really be having a problem caused by mast cells that gives them the symptoms of migraine? Not always, but sometimes people can have funny skin spots as part of their mast cell activation syndrome, meaning they get these little red dots or dark brown dots that become itchy and typically stay there for weeks or longer. They can have fatigue or confusion. They can have headache, of course. More than 90% of people with mast cell activation syndrome have migraine or at least a headache syndrome. They can get fluctuating muscle pain and have other features that I haven't listed here as well. If someone has mast cell activation syndrome, they'll tell you they have certain triggers, meaning they can't stay out in the hot weather for too long. They'll feel flushed, they'll feel lightheaded, and faint very easily. Some people find they can't exercise if they have mast cell activation syndrome, meaning if they try to exercise, the body busts out in a rash or they feel itchy and they have to stop. You may have heard of someone being allergic to exercise. That's what they mean by this, where people exercise and it causes an allergy response in their body. And of course, if the allergy response occurs not only in their muscles and their skin, but also affects the lining of the brain, that will turn on migraine for people. We also know that some people get itchy or get spots on their skin, different than plain sunburn, from regular sun exposure. So they won't get a regular sunburn. They'll say, wow, after a couple minutes, my skin actually itches, or I get these red spots that raised and look like hives from the sun, almost like I'm allergic to the sun. And that's also what they think about with this syndrome. We know stress can bring out this, and also sex and other things too. So if you're seeing your doctor, the doctor may start putting together some of the clues. People who have mast cell activation syndrome typically have identified multiple allergies or feel like they're sensitive to multiple things. Sometimes they have a list of 5 or 6 medications they've had allergies to, or they've got 5 or 6 foods that they have allergies to, or they say, I can't eat certain foods. They just make me feel sick or they make me feel weird. Foods that are very common for this include wheat gluten or dairy or egg. Those are the top 3 that we think of. They'll say that I can't exercise. I feel sick if I exercise. Or I get diarrhea when I have a migraine, which is unusual for a routine migraine. They may have chronic skin issues like eczema or chronic folliculitis, which upon second look actually is a skin problem from having these mast cells being too active. They commonly have asthma or rhinitis or other features of local inflammation that are of a chronic nature. So sometimes these folks with mast cell activation syndrome actually have dermatographism, and that's what these pictures are showing you on your screen. These are pictures of people who scrape their skin and wait a couple minutes, and instead of it becoming just a red scratch like most people experience, these folks actually get a raised level and sometimes a white clearing around the raised level that they call skin writing, and the fancy word for that is dermatographism. We know that dermatographism is present in the normal population. About 5% of people in the United States have dermatographism. But if someone has prominent dermatographism and then has recurrent migraine episodes, as well as things like abdominal symptoms or diarrhea, or they're prone to have lightheadedness or fainting with low stimulus or with temperature change, we start thinking maybe they have a mast cell problem. And you treat mast cell problems differently than you do typical migraine. Here's again those skin spots that I mentioned. This is called Uticaria Pigmentosa. And these are actually spots that are brownish or reddish sometimes, which itch commonly if there's been a temperature change. So if someone comes out of the shower, they'll have a mole or a spot in their skin that actually itches for a while. That temperature change causes sometimes histamine release and makes it itchy. But these actually stick around, not just for a day or two. They're usually there for months and sometimes longer. They're frequently misdiagnosed as a chronic skin issue like folliculitis or eczema. If there's question as what they really are, a biopsy will actually show a whole bunch of these things called mast cells, which would confirm the diagnosis. Things like eczema and folliculitis shouldn't have an overtly large number of mast cells to them, so it's quite simple once a biopsy has been done to prove that's what that is. And Uticaria pigmentosa typically comes from 2 active mast cells. So the last thing about this is, how do you make a diagnosis? If you see your doctor and you're worried about something called mast cell activation syndrome, what can you and your doctor do to look for it? And the answer is mostly take a detailed history and be aware of that syndrome in general. We know that the diagnosis is made best when you hear the clinical symptoms and people start having multiple symptoms that relate to a mast cell sensitivity. There are some blood tests you could do, like something called a tryptase level, although this is notoriously unreliable. If it's elevated, lots of things can make it elevated beside a mast cell problem. And we also know that if it's elevated, or if it's normal, people can have a serious problem with mast cell activation syndrome and still have normal tryptase levels. Then there's other things that can be looked into, like prostaglandin levels in the bloodstream, urine studies that look for histamine or something called leukotriene, and if really needed, a bone marrow biopsy can show that the body makes more mast cells than it's supposed to. So how do you treat this? If someone comes into the clinic and they've got symptoms suggestive of migraine, but then they've also got these other features, you can use medications like Zantac or Zyrtec, which are quite common medicines. those can make some people have much less episodes of migraine and have less episodes of diffuse body pain if indeed they have a mast cell problem. The issue, though, is that mast cells can be active not just through where those medicines work. Sometimes people have mast cell symptoms and they don't have anything to do with Zantac or Zyrtec. They're actually causing trouble through different types of markers that they release. So there's other medicines that theoretically can be used out there, like aspirin or something called Singulair, which is classically an asthma medicine. I bring this up not because I think anyone who's listening should try this, but just to be aware that there's other treatment options if the big picture looks more like the body's prone to have allergy in general, and maybe that's the source of people's migraine headache. Indeed, you can cure some people, or at least dramatically reduce episodes of migraine if they have that caused by mast cell problems just by using some of these therapies. And I should pause and mention to you, anyone who's listening in, indeed do not do any treatments without discussing it with your doctor or healthcare provider. So there's a few medicines that are used in the migraine world that are very notable for their ability to work on mast cells, like amitriptyline, which is also known as Elavil, and it goes by other names too. We know that Benadryl can shut off a spike of migraine, and some people even use it to prevent having migraine, and that is a very potent mast cell stabilizer, meaning it makes mast cells not to elevate into a problem level. We know that an antibiotic called doxycycline can actually be very effective in reducing symptoms for people who are prone to get headache as well as these other features. Not because it treats infection like the name would imply, that is the name of an antibiotic, but because at low doses it knocks out one of the inflammation paths that these mast cells become active in. And there's other things like periactin and Phenergan, which are used for migraine prevention, but actually have pretty strong roles in calming down these cells that we call mast cells. So this is another picture to show, if we're not sure, if someone comes to our clinic and we're not sure if they have a mast cell problem or not, we know the blood tests are quite unreliable, sometimes we'll just put them on what we call empiric therapy, meaning they've got enough symptoms that 4 weeks of this trial might be enough to decide if they have this trouble going on or not. If they're better, it really would suggest they've got a problem with mast cells. If they're not better after 4 weeks, it doesn't mean a whole lot. It just means that these medicines didn't help them. They still might have a mast cell issue, but it is less likely. And I've got one patient specifically who I won't forget who had not only recurrent migraine episodes that were really not responding to any typical treatments, but she would have flushing episodes and near fainting episodes, and her hands would at times become inflamed and red as part of her pain episode. And indeed, for her, we felt that she was having a mast cell issue, so she got placed on these therapies. And when we saw her back in clinic next, she had been doing fantastic, and she had described having only 1 or 2 headache episodes in the last several months, mostly because of this therapy. The picture there on the bottom right-hand side is not to scare you away from mast cell concept or from allergy concept, but to show you that you do want to know what you're doing. So again, talk to your healthcare provider before doing any kind of therapies or medication changes. And just like this guy is trying to figure out, why is everyone wearing a hazmat suit? What could be so interesting that you got to wear a hazmat suit? I'm going to walk over in my shorts and shirt and look and see what they're doing. So please don't do that at home. So this is a video clip for a patient of mine who was describing symptoms of migraine too. And what he meant was that he was actually feeling quite well, and he was backpacking in South America when he got a GI flu or a GI illness, and then developed persistent headache that's been really unresponsive to treatments over time. But he also developed abdominal symptoms. He would frequently get diarrhea, and he would frequently get fainting episodes and flushing episodes, and his blood pressure would be high 1 minute and low the next minute, and all this seemed to occur within months of getting this intense stomach infection. After puzzling through his case, it turns out he also has turned on or irritated these allergy cells in the body called mast cells. And so he is responding better than anything else he's tried along the way to therapies that calm down mast cells. So I do want to bring up this concept. If people have an allergy irritation, they can get near fainting episodes, something called POTS syndrome, which stands for Positional Orthostatic Tachycardia syndrome. And this is where people's blood pressure is not regulated correctly. And we know that an allergy response can irritate and bring out these symptoms in certain people, mostly because of the inflammation cells that release not only inflammation markers, but also release markers for blood pressure and make the blood pressure go high or low or not to be regulated the way it's supposed to. There's even something called hyperadrenergic POTS, which is that second statement. And that's where people actually, instead of having drops in blood pressure where it goes too low for no good reason, they have that episode, but they also can have too high a blood pressure. And so that the heart rate and blood pressure goes too high and then too low, and they can have a lot of migraine and body pain with this. And there's more and more evidence showing that this is related to hypersensitivity to this allergy formation in the body. We know that hyperadrenergic POTS, the one that is seemed to be related to this mast cell concept, is seen in people who have hypermobility, where people get anxiety, tremor, and sweaty extremities during their experience. Over half of them get a migraine during the time they feel lightheaded or nauseated, and they also have generalized fatigue. We know that this can cause fainting episodes because mast cells can release inflammation markers that cause swelling of fluid in the legs and make fluid build up in the legs and doesn't go where it's supposed to. But we also know that epinephrine, which is a fast heart rate hormone in the body, can be released by mast cells, or at least triggered by mast cells, so that people can get a fast heart rate and their blood pressure can go too high at first before it comes down. The next thing I want to talk about is food sensitivities. And this is a very important concept. We know that certain foods can trigger migraine headache. The National Headache Foundation and the Diamond Headache Center have some very detailed food trigger lists that can bring up episodes of migraine. When we look at regular food triggers, we think that if someone's exposed to a food, it causes a chemical reaction that irritates the body and quickly turns on migraine. One of the best examples is using red wine. So if people are exposed to red wine, we know that that can cause an irritation of the body and make them prone to have migraine episodes. However, there are certain foods that actually don't cause their response within minutes or even hours of their exposure. Certain foods can cause a subtle, gradual increase in inflammation, and the most notorious for this is wheat gluten. Wheat gluten, if someone's exposed to it, usually isn't a problem. But for many Americans, wheat gluten actually causes a building inflammation of the gut. And over time, that inflammation can not only affect the gut and cause the gut to release inflammation markers, but it can also affect other portions of the body. So people who are truly gluten sensitive can actually get chronic migraine, can get chronic abdominal pain, can get sleep dysfunction, confusion, and diffuse body pain, all related to the body's immune response to wheat gluten. We know if you're looking for celiac disease, which is gluten allergy in this country, there's about 7 or 8 important tests that all have their own bearing on whether or not someone has gluten sensitivity. One of those tests is the IgG test for wheat gluten. You can actually do an IgG test for about 100 to 200, sometimes even 300 foods to see if someone's blood is inflamed with exposure to certain food subtypes. And this is that concept of IgG food sensitivity testing. We know that it can be a challenge for people who are prone to get frequent migraine or recurrent migraine to figure out what foods over time may be bringing out or lowering their sensitivity. And clearly, not everyone who's prone to have episodes of migraine has an intolerance or sensitivity or allergy to food. But we do know that people who develop gut symptoms like irritable bowel syndrome or abdominal pain or diarrhea or constipation and have migraine have a higher chance of having food sensitivities than people who don't have the gut piece but have just as intense migraine episodes. And there is a tool you can do, a blood test, that some providers, and not every provider in the United States, but some providers offer this blood test. This blood test is an accepted tool to look for celiac disease, but also for asthma, and also something called eosinophilic esophagitis. But there's now several studies that have shown if you do an IgG food sensitivity blood test for someone who's prone to have chronic migraine, you can actually identify foods that if you take them out of the diet, reduce migraine burden. Let me show you what that looks like. Here I've got a sample of one. So in our clinic, we use a lab readout that looks just like this. And this has your miscellaneous food types on the one side, as well as the body's immune response to them, and they're ranked in there. So this first page showing the IgG4 subtype antibodies looks like a pretty normal study. And this gives you an idea of the things that are looked for on these blood tests. The next page is the same patient, and this shows you where some problems are. So this person, if you look at these blood tests, they have an inappropriate IgG inflammation spike to egg, not only egg white, but egg yolk. They also have a mild response to milk, and they also clocked a mild response to navy bean. In our clinic, for chronic migraine, we're very concerned about people who have egg white or egg yolk sensitivities on this blood test. This patient who allowed me to share her case with you today actually had more than 5 years of some degree of migraine every single day. She is already aware she was sensitive to certain foods, but never really was aware that she was sensitive to egg white and egg yolk. And I never would have mentioned that before we had done these blood tests to her. It turns out when she avoided egg products in general, she had a dramatic reduction from chronic migraine, meaning some degree of migraine most days out of the month, down to having only 2 migraine episodes in the last 5 months. She swears to me both of those were from an egg exposure that she wasn't anticipating, that I find quite hard to believe, but it's not uncommon for people, once they know what foods might be bothering their body, to do incredibly well when they avoid them out of their diet. This concept, this thing called IgG food sensitivity testing, is very controversial. So I want to share with you both sides of the equation. One side is that if the body's prone to respond to inflammation easy, like migraine folks are prone to do, and the body's around foods that irritate the gut or irritates the inflammation system of the body, that might be a way to reduce migraine burden by finding foods they're sensitive to and avoid them. Some folks who argue the other end of the coin say, if you did this blood test to 100 normal people in the United States who don't have migraine, about 30% are going to have elevations on their blood test, and they all don't have chronic migraine, so therefore it's not the source of migraine. The way that our clinic and the way that I like to look at this is that if you're prone to have migraine, even just a little bit of inflammation over time can increase your susceptibility and your likelihood to go into a chronic migraine or to have episodes of migraine occur. And anything that reduces inflammation in the body is good for those who are prone to have migraine. Therefore, doing this blood test, I think, is a very effective and very helpful tool in our patients who've got hard-to-treat intractable migraine. Indeed, some headache centers offer this to all new patients, and many headache centers do not, but it's something that I feel, if you're interested in allergy and migraine, to be aware of this concept. This blood test is not always covered by insurances, so it can be expensive, but the blood test costs less than certain therapies that are used for chronic migraine, and indeed it gives people the empowerment to know which foods to avoid if they're prone to have allergy and migraine, or if they're prone to have GI symptoms of migraine, or prone to have migraine because of exposure to foods. The key to this is that usually people don't know that they have these food sensitivities. So they'll be exposed to these foods gradually over time, and that can be wheat gluten, that can be egg, that can be dairy, that can be other things. And they don't have symptoms the day they eat it. They actually have symptoms weeks later or months later after constant low-dose exposure. Certain foods like egg or wheat gluten are ubiquitous or are present in our diet, whether you want them or not sometimes. And you've really got to reach out and read labels and see what's out there if you're really trying to avoid these foods. So most patients aren't able to identify an egg sensitivity or a wheat gluten sensitivity just by seeing what their headache pattern has done over time. They either have to do blood tests or do an empiric trial. There's a study conducted at a different clinic than ours that looked at 500 patients who had chronic migraine. And when they applied this type of blood test, called an IgG food sensitivity screen, they found a high level of sensitivities, meaning that about 24% of the people had some degree of food elevation. The top 3 finishers, and their study looked at more than 100 foods, if I remember correctly, but the top 3 types were what we see in our clinic too. Number 1 is wheat gluten, number 2 is egg, and number 3 is dairy. And so if someone isn't able to do the blood test, or if someone is willing to do a diet change without doing blood tests, and if I had to choose 3 foods that people could eliminate to see if the migraines got better, it would be those 3. It would be egg, it would be dairy, and it would be wheat gluten. Typically they do one at a time. So you avoid wheat gluten for 6 weeks and see if things look better. If not, you can bring it back. Do the same then for egg, and then do the same, of course, after egg for dairy, and see what someone's experience is. Sometimes 6 weeks isn't enough to improve chronic migraine, but usually people feel like they're more alert, more attentive, they have less other symptoms, they're willing to continue avoiding that food for a longer period of time. If someone's considering going gluten-free for 6 weeks, we don't encourage our patients to go to the grocery store and buy the expensive gluten alternatives. We tell them simply to avoid gluten out of their diet. If after 6 weeks they need to maintain that diet, that's when it's worthwhile either meeting with a nutritionist or learning more about how to generate meals and foods that are nutritious but also taste good but are also gluten-free. So a couple things to summarize. First of all, we know that that migraine can look a whole lot like sinus allergies. Plain migraine can cause irritation of the nerves that cause nasal stuffiness, that cause eye tearing, that cause facial swelling, and that can all be migraine. But we also know the other direction is true too. People can have allergy and inflammation that triggers or brings out migraine. Not always through the sinus cavity. It can be irritation through the gut from foods that irritate or bring out inflammation. It can be from environmental pathogens that irritate or bring out inflammation of the sinus cavities that then trigger migraine. We know that mast cells regulate allergy symptoms, and people who are prone to have other pain syndromes, like painful bladder syndrome or fibromyalgia, are more prone to have mast cell sensitivity than other people. People with flexible bodies are more prone to have active mast cells compared to people who don't have flexible bodies. We know that patients may trigger migraine when they're exposed to an allergy, and that's the food sensitivity that I've been talking about, but that's also those animal studies where once they expose an animal to their allergen, you actually saw inflammation in the lining of the brain. And also, research in this area may lead to further treatment options. Medications that were thrown in the scrap heap as not effective for treating allergy might be effective for treating migraine. Medications that are prone to stabilize these inflammation markers might actually be very effective to prevent migraine. And learning more about this, mostly in order to empower our patients into how to get better from chronic migraine by reducing inflammation, seems like a very reasonable option to do. And I think that's my last slide before I jump into some questions. I do see some questions out there, so let me answer some of those questions in front of us. All right, so here I'm going to read this question out loud, then I'll answer it. It says, can sinus surgery to help congestion drain, aid in migraine relief? And the person writes, I seem to always be inflamed, and a CT scan showed severe infection. So the first question about that, for sure sinus surgery can aid migraine relief. This is a very debatable topic, and the short answer is yes, it can, although the data on that is not showing dramatic long-term benefits from what I'm familiar with. Some people get better because of reduced inflammation because of the sinus cavity surgeries, and some people actually might improve not from the sinus surgery itself, but from the anesthetic or anesthesia used to put someone asleep during sinus surgery. We have some patients who respond for 3 or 4 months every time sinus surgery is done, and yet we think it might be the actual anesthetic calming down centralized migraine and building up over the course of months and having nothing to do with the actual surgery. There is some evidence that suggests if 2 areas of the nose touch inappropriately, what they call a nasal contact site, that can generate migraine too. Next question I see here is, can long-term use of triptans make a person more susceptible to migraine? What an interesting question. So we do know that triptans, which are medicines used to treat spikes in migraine attacks, the most commonly being things like Imitrex, Maxol, Relpax, Emerge, Frova, and the like. Those medications, if they're used too often, can irritate the nervous system and bring out increased burden of migraine. So if someone uses triptans every single day for 7 days, that by itself doesn't usually worsen someone's migraine pattern. However, if someone uses triptans like Maxalt or like Relpax or those types of medications 4 days a week, and they do that for months, over time that can actually increase the frequency and increase the burden of migraine, or at least so it's thought. There's very little research to support that use, but in clinical practice, a lot of headache specialists, and myself included, have actually seen that paradigm where the more frequent someone uses triptans, the more likely it is to bring out or irritate the migraine pattern. Of course, if that scenario is encountered, the solution is to avoid triptans for a while. Usually in our clinic it's 2 months, or we switch to a different triptan, or even use a different therapy altogether to try and get in front of that migraine episode and rest the nervous system. And anecdotally, after 2 months, the nervous system is many times naive again, meaning you can use these medications without bringing up the frequency of headache as long as they're used less than 3 days per week on average. Let me see if there's any more questions that are been submitted to us for today's discussion.
It looks like we do have one question from Joy, and she wants to know if barometric pressure changes cause in migraine.
What a fantastic question. And so to answer that, we do know that about 1/3 of people who have migraine verbalize some weather sensitivity. And there's been various studies on the topic. The most reliable weather change factor that seems to be related to migraine susceptibility is actually humidity change and temperature change. and those are associated with barometric pressure change. In the study that I'm quoting, barometric pressure change wasn't as predictable as weather change or temperature drop, but indeed those are kind of related. There's some theories about why that might happen, and those range from the fluid that is in everyone's brain being affected by pressure gradients and barometric pressure, to the body having a normal inflammation response to pressure change, or to the nervous system itself, the brain itself, being responsive to weather stimulus through areas of the brain called the hypothalamus, which regulate our sensitivity to light, sound, but also to daytime and nighttime changes and weather changes. So people who are prone to have migraine are more likely to be sensitive to weather change than other folks are. I'm trying to see if there's any other questions that have come in for now.
One question from Teresa. Is an allergy skin test the same as an IgG testing?
Oh yeah, I wish I'd covered that, and I was trying not to cover too much at once. But the skinny of that is absolutely not. So the most skin tests done by allergists are looking for the IgE inflammation pathway. What that means is if someone eats a shrimp or eats some food that their body's allergic to, the IgE pathway makes them have swelling of their lips, fast skin rash. Usually within a couple minutes to hours you see this response occur in somebody, and that's an IgE-mediated inflammation pathway. That's what they're testing with skin tests. If someone has an IgG sensitivity, they don't show up on those skin tests at all. Sometimes you can see both IgE and IgG in the same person, but no, an IgG blood test is very different than a skin test. Sometimes allergists will comment that you have no IgE irritability and therefore no food allergies, where you still may indeed have an IgG sensitivity that's bringing out some of the migraine symptoms or bringing out other symptoms. So indeed, if someone is suspicious about what we've talked about in here, either food sensitivities or other sensitivities, if they've seen an allergist and they've done skin testing, it would behoove them to ask about IgG inflammation or IgG blood tests. Please keep in mind that not all physicians and not all allergists are under the same mindset that IgG blood tests are helpful. Some allergists say it's a waste of time because it doesn't predict migraine, it predicts inflammation in the body, and yet my opinion and others around the country who share this opinion would say that if your body's prone to have migraine and you have even a little bit of inflammation in the gut from recurrent exposure to certain foods, then avoiding those would really help migraine. And it's a treatment option that I think people should be aware of. Indeed, if you've had the skin testing, you may want to look into IgG food sensitivity testing. You can Google search that or look that up on your own. There's plenty of information online about that, and perhaps talk to that provider about what their thoughts are about it. Looks like that's the last question we have, and also we're about out of time. I really appreciate your interest and folks around the country joining us today for this webinar. If you do have questions afterwards, I would encourage you to visit the National Headache Foundation website, as well as to look at other resources on that website for further education. Everyone have a very enjoyable rest of the evening, and thanks again for your time.
All right, thank you, Dr. Cooper, for joining us, and I'd like to invite everyone to join us for the kickoff of Migraine Awareness Month, which is beginning June 1st, and have a great evening.